Welcome back. I am Jacob Harris. This is All or Nothing, and today we're going to do a blood analysis episode. So I have been kindly given some bloods by a friend of a friend. We're going to go over this person's bloods. We're going to obviously keep them anonymous, and we're just going to basically list, a few things about the person so that you understand who they are and what their kind of situation is, and then we're going to go over them. Connor's going to give us some answers that we're probably not aware of, and just kind of show you what a brief one looks like. I don't say this at the start of the podcast, but I should a little bit more often. This podcast is brought to you by Pet Test Australia. If you didn't already know that, now you do. Follow them on Instagram when it stays up.
Everything stays also for entertainment, educational, and hypothetical purposes only.
Yes, we are not recommending anything at all. At all. Do you reckon the AI picked that up? Pick it up, AI. We are not doing that. All right? Don't fucking demonetize this video, even though it's not monetized because I don't have enough followers. All right. This person is around about our age. I think he's kind of in between your and my age. So this is a male. This is a male. What are you? You're 42, aren't you?
Yeah, exactly. Yeah.
So, yeah. As far as I know, he is a male, around about 28 years old, 29. He is around about the 130 range, I believe, or between 130 and 140 in terms of kilograms of body weight, about 5'10", if off the top of my head. And there's some basic metrics so that you can kind of picture this person that we're referring to. So recently had some bloods done. We're going to go over them in the order that they are done. And if I can be bothered, I'll snippet some of these. I'll take a screenshot of it so you can just see the results, and we'll put them on the screen and stuff like that as well. So to start off with, Connor, tell us a little bit about these ones.
So in terms of his hematology, the panel actually looks relatively good. I don't know the client as well as you. There could be some context there that may show some things that maybe aren't quite as good. You did say he was about 130 kilos. So hemoglobin, which he has a hemoglobin here of 140. That is a little bit on the lower side for someone of that weight. Obviously, the more weight you have, generally the more oxygen that you're going to have to deliver to your body. So the higher you would generally expect your hemoglobin to be in order to allow for an increased oxygen delivery capacity. 140 is clinically normal. Obviously, these ranges are given based off normal weight people. It's just an average. It's not kind of taking into consideration whether you're a large individual or a small individual. 140, again, clinically normal, but I would say probably a little bit on the low side for his weight. If he was an athlete, for example, I would definitely be trying to push that up because obviously less oxygen carrying capacity is going to have a reduced performance benefit because you physically can't get the oxygen to your muscles that they need. There's really nothing else that is particularly wrong with this panel. Just to give a little bit of brief oversight, the other markers within the panel that you're generally going to be looking most at is the red cell count, so how many red cells are in the blood, hematocrit, which is a marker that is effectively taking how much fluid and how much solids in the blood. So the higher the percentage of hematocrit is, the thicker your blood's going to be, the lower the opposite. And then another one that's semi-important in the red cell count is the RDW. This is measuring the smallest and the largest red cells within your blood and taking a difference between the size of the smallest and the largest. The larger the variation, the less consistent it is likely that your micronutrient intake is. So there's going to be basically inconsistencies in the way your body is able to produce red blood cells. So a higher RDW is likely due to the fact that you are lacking one or multiple micronutrients that are required for the production of blood. Then we have the white cell counts. Obviously, white cells are effectively your body's immune system, how your body fights different colds, bacteria, stuff of that nature. You can kind of see what's going on if your body is fighting certain pathogens and stuff by the ratios of the white cells that make up the white cell count. Everything here looks pretty normal. There's nothing there that is alarming whatsoever. Platelet count. Platelets obviously what causes blood clotting. His are normal. And then you've got mean platelet volume. Again, his is normal there as well. So pretty good overall. Might be a few little contextual things that might be off, but without knowing more, I would generally say that was a relatively healthy blood count.
Cool. All right, we're moving on next to the hemoglobin ACL.
Hemoglobin A1C.
Oh, I've not read that properly. Hold on.
Yeah.
It does say A1C.
Does, yeah.
My apologies.
Now, here's an interesting one because me and Jacob have actually spoken just briefly over this. This is one where you'll get a good idea of why single markers are very rarely a good thing to throw your hat on altogether. Because right here we have what looks like a very, very healthy HbA1c of 4.9%. Fantastic. Long-term blood glucose management going off that marker alone is terrific. You would have no expectation that this person is in risk of kind of metabolic disease or anything of that nature. I think we'll probably skip over a couple of the markers here and go straight to the one that I'm kind of talking about next.
Okay.
Just so it makes sense.
Mm-hmm.
If we look at his glucose here, we have a fasting blood glucose of 5. And if we scroll a little bit further down to his insulin, we have a fasting insulin of 20. So fasting blood glucose of 5, not a huge deal, a little bit on the higher end, pretty normal, nothing that's alarming, again, in isolation. The fasting insulin of 20 with the fasting blood glucose of 5 is where things do become quite alarming. That is a significant elevation in insulin in order to manage and keep blood glucose at a level of 5.0 millimolar. There is a calculation that you can run called a HOMA-IR. I might even just quickly try and pull this up so that we can run a HOMA-IR on this score for you real quick.
Just while you're doing that, so just going off the fasting range that they've put there is 2 to 12, so that you would be more comfortable seeing something that was, at least maybe under 10 or something would be more normal.
Yeah, so really 5 to 6 is about the upper end of what I'm wanting to see for a healthy individual in fasting.
20's not ideal then.
Yes. And now, so when we throw this into a HOMA-IR calculator, this gives us a score of 4.4. So HOMA-IR is basically a calculation that is measuring how much insulin is required in the blood to keep a given blood glucose level, so almost like an insulin to glucose level. You want the number to be lower, below a 1.0 kind of is ideal. For athletes, I'm kind of chasing more like 0.7 or below. He has a measurement of 4.4. So about a 4.4 times higher risk factor, or 4.4 times worse of a insulin sensitivity than what would be considered ideal or optimal. Now, you often see this before you see any long-term blood glucose dysregulation. So your body is pretty, efficient at managing blood glucose levels. It kind of has to do it. It's extremely important to our survival. So the first thing that happens when there starts to be a dysregulation in, say, insulin sensitivity and your body's ability to manage glucose with a normal amount of insulin, the easiest thing for your body to do is just increase that insulin production. So if X amount of insulin is no longer getting the job done, now your body just starts producing that little bit more to send a little bit stronger of a signal to then, keep blood glucose down at a level that it needs to be. There will eventually become a point where your body just cannot keep producing insulin to manage that blood glucose. And at that point, now's when you actually see the blood glucose level start to become an issue. This can go on for years before you actually see dysfunctional blood glucose. But because you're seeing this going on now, you can get ahead of it, basically. You've picked up that you are going to have issues controlling your blood glucose in the future if this continues. You still have healthy HbA1c, your fasting blood glucose in isolation is still healthy, but this is going to become an issue in the next 6, 12 months, 2 years, whatever. So that's something you can definitely look at as a early warning sign before some of your other markers may show issues.
Would you classify this as like pre-diabetic yet or not? Wouldn't say it's pre.
It's not pre-diabetic. His actual blood glucose management is actually pretty healthy. So pre-diabetic is usually based off the HbA1c marker, which is a measurement of how much glycation or sugar damage is occurring to a red blood cell over its rough lifespan, which is about 4 months. So that's going to tell you pretty much what your blood glucose is around the clock.
So this is pre-diabetic though?
You could kind of look at it like that. Yeah, it's euglycemic insulin resistance is kind of what it would be referred to. So he's maintaining completely normal blood glucose, no issues. But the way, okay, if I put this in a car mechanism, like if I try to put this in a bit of a car's fucking, if it takes 3,000 RPM in sixth gear to keep your car at 100, with insulin resistance, now all of a sudden your car's at 7,000 RPM on red line in sixth gear to keep your car at 100. Still doing the same thing.
Just working harder.
Your body's working way, way harder.
That's not ideal then.
Not ideal. And yeah, so most likely, so say this person never had any intervention. If we were to take bloods in 12 months from now, there's a good chance that our HbA1c is now no longer going to be in a healthy range.
Okay, because we went over a couple there. We started with the hemoglobin A1C, not ACL, whatever the fuck I said. CRP, we're not really going to look at. That's pretty normal anyway, right?
Very normal. Yeah, it's good. I'm
still learning about this as well. The CRP is sometimes we see that elevated when like people are like sick and stuff. Is that one that is, or am I thinking of the wrong marker? Yeah, because I think mine came back a bit shitty once because I had a cold right before I did my bloods or something.
Yeah.
Then we went glucose. We skip past the lipids. Did you want to talk about those?
We will have a quick talk about the lipids again because it just ties into some other issues that he has that we'll touch on a little bit later.
Yeah. Or is this the order you want to do them, or do you want to go over some other stuff and come back to the lipids and make that the last thing?
No, lipids make sense. We can run over the lipids.
Right. So you can see there's a couple of things like the HDL, LDL, and then the non-HDL cholesterol. They've actually highlighted those ones themselves, right? On there, they've actually come up because they're outside of the range.
And the hilarious thing is the thing I'm most concerned about is the one thing that's actually in the range, especially in the context of the entirety of the blood sites.
Watch this video till the end to find out.
Yeah, we'll go into it. And also we'll state this is a non-androgen using, or at least a non-superphysiological androgen using individual, because when you are looking at lipid panels in the context of an androgen user, things are going to generally be a little bit different, especially in relation to HDL. His lipid panel kind of almost does look like he is an androgen user, despite not being one. So he does have a slight decrease in HDL, only mildly below the reference range. From my interpretation of the data around cardiovascular risk at the moment, I have less concern around HDL levels in comparison to LDL, particularly in the context of enhanced individuals where HDL is just about impossible to control. Moving on to the LDL, which is the area, more so ApoB, but ApoB, LDL is a part of ApoB, so they kind of sort of one and another. The LDL is at a 3.4, which is in some reference ranges, that'll still clip into the reference range. Depends on which lab you're with. Again, some of the reference ranges for this aren't particularly ideal. It's a mild elevation. It kind of goes along with the fact that he's generally pretty metabolically unhealthy. He has some insulin resistance going. There's obviously a little bit of lipid metabolism and utilization issues as well. As we get into, he most likely has fatty liver a little bit later. The triglycerides that he has here, now, as I've just said around the fatty liver, the triglycerides being at a 1.7, despite technically being in the reference range, is where I am most concerned for a few reasons. We've already touched on the insulin resistance that is occurring, insulin resistance being one primary driver of non-alcoholic fatty liver disease, which is called something else now, but I don't know what the new name is. Another thing that is a strong driver of fatty liver disease is elevated triglycerides or fatty acids in the blood. A few reasons for this. Elevated triglycerides in the blood directly impacts insulin sensitivity, so you have a further worsening of insulin sensitivity. Also have increased ability to store when you have more free fatty acids and triglycerides floating around the blood. The combination of insulin resistance with elevated triglycerides makes things a hell of a lot worse. If you throw in a lot of fructose as well, where you have the liver converting the fructose into triglycerides at the liver to then be possibly used as energy. If not, it's then stored as fat, often on the liver itself. This individual also has a large waist circumference, which is another strong risk factor that is associated with non-alcoholic fatty liver disease. And if we further push on down towards his actual liver panel, which is towards the very bottom. Now, again, keep in mind, this is not an athlete, non-training person, so the liver enzymes here are going to be a lot more indicative of actual liver damage than, say, a hard training athlete. We have a GGT of 69, which for the most part, that's kind of measuring your body's ability to produce glutathione and detoxify. Elevations here can be a few different things. Bile flow issues can be one thing that causes it. There can also just be other issues with some of the stuff that is needed to produce glutathione itself, as in like the substrates. We have AST and ALT quite significantly elevated. ALT significantly more elevated. ALT does tend to be a little bit more liver specific than AST in terms of those two enzymes. So when you do have a pretty significant, larger increase in ALT in relation to AST, that is also another pretty good indicator that what you are seeing is.
PedTest Australia is a WA-based company providing at-home testing kits for a range of black market substances, underground or counterfeit drugs that can often contain a different substance than what they claim, or nothing at all. In 2024, 5% of oil-based steroids contained no active ingredient. Oral steroids were even worse, 12% contained no active ingredient. PedTest Australia kits provide a quick and cost-effective method of screening products before they are used. Kit results help users make informed decisions about substances they choose to take and therefore reduce the risks they are exposed to. Don't take chances with your health and gains. Test it before you take it. Go to pedtestaustralia.com to order your test kits. Bulk Gym Chalk Australia are your go-to suppliers for gym chalk. Whether you are doing powerlifting, weightlifting, strongman, gymnastics, or running a competition event and need bulk supplies and prizes, they've got you covered. Options include block chalk, bowl chalk, liquid chalk, or invisible liquid chalk for those gyms where you aren't allowed other options. They even have a range of athlete recovery bath salts to soak those training aches away. Check out the range at www.bulkgymchalk.com.au.
Actually liver stress, even if it is in the context of an athlete. Generally, you're going to see ALT and AST similarly elevated. If that athlete is seeing an elevation in both, but ALT is like way higher, pretty good indication that what is causing that elevation is maybe somewhat training related, but also some aspect of liver dysfunction as well. So yeah, overall, pretty horrendous liver panel with no good reason as to why any of those markers should be elevated through training or anything of that nature. So the combination here, we have pretty much every single warning sign for non-alcoholic fatty liver. Large waist circumference, elevated triglycerides, insulin resistance, and then obviously the actual liver dysfunction that's been shown in the markers itself. I believe there is actually a non-alcoholic fatty liver index or calculator or something that you can use, which uses, I think, GGT, waist circumference, something else. There's a couple of other inputs, but you can actually go and use your blood marker and your blood markers and waist circumference in a calculator to kind of give yourself a little bit of a risk factor as to what you are with non-alcoholic fatty liver disease.
Not ideal. I would say, yeah, there's a bit going on here. Some context. This individual has experimented with steroids in the past or just generally testosterone, has gone through cycles on, I would imagine, unregulated cycles in terms of overall dosing and sources, and then ended up just coming straight off a cycle, did no PCT, and also has recently experimented using a little bit more again, but a negligible amount. So when asked about it, he had stated that it was 10 units. Now, I don't inject myself very often at all. I don't do it at all. I will at some point, though. It'll happen at some point because I'll get old. But yeah, he has basically said he's on 10 units or 0.1 of a mil of testosterone a week, which from my understanding is using that terminology. If it's 0.1 of a mil is a negligible amount that will do nothing, which would maybe explain a little bit about some of the markers underneath the ones we were just reading. And also he's been using Retta on and off as well, and suffers from what he describes as horrendous reflux and indigestion, and has for quite some time. But then also in the same breath says things like, I used to drink 3 Red Bulls a day and now I don't do that. And then and it's better. And then I go, that sounds about right. So testosterone, just to touch on this one, because let's face it, everyone's always, when people get their bloods back, it's the first thing they look at. On a marker, or the markers they put are 6 to 28. That's the one we use in Australia. But I think we've talked about this before. It's a bit of a bad marker. If you're 6.1, the doctor will be like, no, you're all good. Don't worry about it. And same the other way around. So his total test is 4.6 on a scale of 6 to 28. But as you said, that scale is different. When I did it, my scale was 10 to 35.
It just keeps getting worse.
Yeah. And then his free testosterone is 116. But then also, I've just seen this, and I don't know if this marker is correct, but I remember thinking about this. Generally, you can have a larger level of free testosterone if you have lower SHBG, right? Because it allows for more free circulating testosterone. But he's actually got low SHBG as well, and then his free test is still low. So I'm curious to hear about that, Connor. What do you have to say about that?
Can't have high free tests if you don't have high total tests. There's no total test to be free. Free test isn't going to be high either. You could have 0 SHBG and it's still going to be low.
Lucky the SHBG isn't high though, right? Because I remember when I got mine done and mine was quite high because I'd been cutting and stuff and it was in a different spot. I can only imagine how low his free test would be if the SHBG was 50 or 60.
And one of the things that causes elevations in SHBG is liver dysfunction. So if the liver keeps getting worse, then chances his SHBG goes up is pretty high.
Right. Do you have anything else to say about these markers and what you think's kind of going on? I mean, it says low testosterone level. At least they've written that.
Look, if he's taking 0.1 of a mil of testosterone, the blood work reflects sort of that. I mean, it probably shouldn't be the level of suppression that he's seeing. Actually, let me see where his FSH and LH is, because
I will point out that the chances are that he's probably been on it a week as well. So I don't know that it.
Yeah, I mean, he's got an FSH of 4 and an LH of 2, which is pretty normal. It's towards the bottom end, sort of showing that the HPTA is not really interested in producing anything else. So with low testosterone, you've usually got one of 2 things that happens. You either have your body will, particularly luteinizing hormone, it'll skyrocket it. It tries to increase the signal to your testicles, then get your testicles to make up for the lack of testosterone production. Typically, when that's the case, testicles are what's the issue. Your pituitary and your hypothalamus are signaling correctly as part of the feedback loop going, hey, motherfucker, we need more testosterone, make us more testosterone. But then the testicles are just saying, no, we're done, we're out, don't want no part of this. His case, his testosterone's low as fuck, but also the signaling to tell his testicles to make more testosterone is towards the low end. So his body's not actually trying to increase the production. A few different things going on there. It could be something to do with partial shutdown from the fact he's taking a minuscule dose of steroids. Could be to do with the fact he's quite unhealthy. A little bit hard to tell with these things when he has been incorrectly experimenting with steroids.
Yeah. Would there only be benefits if he'd been including retatrutide? I know he's lost a bit of weight on it. Only be benefits with that, or do you think that because of the situation he's in, is there any negatives of taking Reta? Or
Look, contextually, 100%. The guy is metabolically extremely unhealthy. Retatrutide has been pretty clearly shown to improve outcomes with non-alcoholic fatty liver disease. So unknowingly, he's probably actually helping that quite a lot. Directly through the drug with the glucagon agonism, and secondarily through the weight loss that occurs from the drug. The one thing I will say about the retatrutide, because of the GIP, it does stimulate insulin production to some degree, as well as the glucagon stimulating glucose or glycogen breakdown at the liver to be released into the blood system as glucose. So people who are using retatrutide may actually see slightly higher fasting insulin levels. So it's possible that, and I'm not talking about to the degree where he would be normal again, but maybe he was only at a 15 or a 17 if he wasn't on retatrutide. The retatrutide itself can, and normally and healthfully so, it's not an issue if that is the case, but retatrutide can cause the increase of insulin production as well.
rough times. I'm just trying to see what we've not gone over. Everything else.
One other thing I will quickly touch on, being hypergonad, strongly linked with issues with blood glucose management as well. One of the things that I have found more beneficial in people who have had longer term blood glucose dysregulation and have also been towards the lower end or legitimately hypergonad is actually the use of testosterone at normal physiological levels. But bringing them from that deficit towards a healthy range is something I have personally seen improve outcomes with stuff like type 2 diabetes and insulin resistance.
Okay. Right. Noted for this man listening. I think we've touched on. We didn't talk about cortisol, but that looks kind of in range, right? It's, what was it, 219?
I'll quickly touch on the estradiol as well. Just estradiol, it's well within range, but as men, we produce our estrogen as a downstream product of testosterone. Testosterone is either 5-alpha reduced into DHT or it's aromatized into estrogen. We don't produce any estrogen directly. It all comes as a byproduct. He has an estrogen of 83, which is pretty normal. It's about where I want to see most people, depending on where your testosterone levels are. But given that it's produced from the testosterone, which is almost non-existent, probably a fair bit of aromatization that's going on. So we've also established the individual is overweight. The aromatase enzyme is predominantly produced in fat tissue. The more fat tissue you have, the more aromatase enzyme you're going to produce. The more aromatase enzyme you produce, the more of your testosterone that ends up getting converted into estrogen. So he's probably having a good amount of testosterone that he is actually producing, ending up being converted into estrogen, which is then keeping the testosterone levels on the lower end. Estrogen is also one of the primary inputs for negative feedback and telling the hypothalamus to reduce signaling to the pituitary, to then reduce signaling to the testicles to produce more testosterone.
Sounds like this guy needs TRT.
Possibly, unfortunately, yeah.
Yeah. Well, all good, bro. We'll all end up on it one day. You'll just get there first. Not Connor, though. Connor's going to do a full Pete Rubish and go natty in 10 years.
I'm already 11 years deep, mate.
Yeah, might as well keep it going. Yeah, Connor got testosterone for his 15th birthday party. It was just needles sticking out of the candle. Sorry, candles sticking out of the cake. Well, I mean, we've gone over the other markers that were the issues anyway, and I think you've pointed out a couple of those main ones. Obviously, it sounds like, I mean, correct me if I'm wrong, it's probably not too complicated and should be monitored by his doctor and things like that. But chances are, if you just got on a bit of that TRT, we're not prescribing this, by the way. This is purely speculation.
Yes.
Got on a bit of TRT, kept up the Reta, improved his diet tenfold, because people tend to be like, it's not that bad. And I'm like, I reckon it is.
Fiber intake's a big one as well.
Fiber intake as well.
Yeah.
Overall, the answer is always the one that people don't want. It's like exercise, healthy diet, and you'll.
This is 100% all metabolic disorder right here. It comes from not moving enough, eating too much, and just generally having an unhealthy lifestyle. It's entirely metabolically related, the issues here. They're all caused by the same thing.
Well, if you're listening, well, I know you're listening, but recommended then, it sounds like improvements need to be made. I would say that, to be fair, as bad as some of these are, they're not like, as you said, like a lot of it is, it's risks of this, or this will happen if this keeps up. Like it sounds like a lot of changes can be made. I mean, some people are in positions where it's too far, things are fucked. You're not in heart failure or liver failure or anything like that. It's just like hey, look, you found this a little bit early, probably a good time to make some of these adjustments. I don't understand the whole thing with Retta. Personally, I can't get my head around what it must be like to be on Retta, but then you've got to eat enough fiber, but then Retta's slowing down your gastric emptying, but then fiber would slow it down even more, which is kind of good because you get full, but then are you getting enough protein in? Are you getting enough micronutrients in? Everybody I know that's on it generally doesn't eat that healthy, so how the fuck are they managing to get anywhere near enough of this stuff in? I really can't get my head around that. I'm sure there's people out there that are using it that are eating really healthy, but I've not met them yet. I've not met one of those people yet.
Every single one of my clients.
Well, I haven't met those people.
Oh, well, not every single one of my clients is on Retta, but every single one of my clients that is using Retta, bar maybe a couple here and there that might be a bit cheeky. Retta should be secondary to a lifestyle change. And me and Jacob have discussed this a bit. The dosing that you see within a gym population versus the dosing you see within general population is not even the same. Most of the gym users don't even get to the bottom range of the clinical retatrutide dosing because they're already having a lifestyle in place with dietary choices, high fiber, high protein, stuff like that is, helping with appetite regulation as it is. And then they're just using this little bit of something on top to augment it. You've got the other population of people who are doing none of this. They're emotionally driven to eat. They're driven by dopamine to eat. A lot of their eating isn't appetite regulated anyway. It's comfort regulated. So the doses that they have to use with no lifestyle changes in order to get results end up being 2, 3, 4, 5, 6, 10 times higher than the doses that get used in the actual athletic population.
So basically, if you're not someone who's already dieted before, or you don't have a level of self-discipline, which if you're average general person, population, you won't, you're going to have to use more.
Yeah. But that's start working towards option one though.
Well, yeah.
I guess if it's between you being fucking way overweight and putting yourself to an early grave, I 100% think that even if you're not going to change your lifestyle, losing weight with retatrutide is still going to be beneficial.
Absolutely.
Changing your lifestyle and losing weight with retatrutide, significantly more beneficial. It should always be the goal to be working towards the lifestyle changes, even if that comes after the implementation of retatrutide. It should always be the goal because you will not maintain stuff when you stop taking retatrutide if you don't make lifestyle changes.
Totally agree. And you already know how I feel about it. You should do the diet thing anyway and just don't even worry about Retta if you are able to, because, people did that for thousands of years without Retta. I get it. Life's tough now, but just try. I am a fat asshole. I will point that out. I have cravings like a motherfucker, especially at the moment because there's some things going on with me and I'm more sedentary and I'm a little bit injured. My brain's like, I'm hungrier than ever. Remember when you were trying to bulk and you couldn't eat? Now, bulking time, baby. Sit down and do nothing and bulk. That's what my brain does, and I'm hungry as shit. But after I get off this call with Connor, or this episode, I'm going to go for a walk because I'm aware that I could just eat straight away, but I'm better off. I'm going to get some steps in, and then I'm going to eat my lunch as normal, all right? Because otherwise I will get really fat, and then I will end up with bloods like this, and I don't want that.
Yeah, honestly, and steps. As far as clearing metabolic issues, movement, one of the best things and one of the lowest hanging fruit that someone with blood work like this could possibly do. Go for a walk after your meal.
Go for a walk after your meal. After you train, do a quick 10 minutes. 10 minutes 3 times a day equals fucking get on the treadmill. We're going to leave it there, and then we will touch base in a future episode maybe. But so far, we hope you've enjoyed this. Thank you, Connor, for those analyses and listening to me mispronounce most of it. I am Jacob Harris.
I'm Connor Walsh.
This has been All or Nothing. We'll see you next time.